Moving toward our last talk, I welcome Dr. Tapan Parekh to deliver talk on adrenal incidentaloma.
Good afternoon, everyone. So, my topic is approach to adrenal incidentaloma. Generally, it is said that in endocrine evaluation, first should be clinical examination and biochemical features, and afterwards it should be proceed to imaging. But what if we have found adrenal mass incidentally on imaging? Let's see. So, definition of the adrenal incidentaloma. Clinically inapparent adrenal mass which is discovered during diagnostic testing for condition that is not related to adrenal, like evaluation for abdominal pain, vomiting, and occasionally on USG abdomen or CT abdomen we have found adrenal incidentaloma. Arbitrary cutoff for evaluation of adrenal incidentaloma is 1 centimeter or more. So how much common is adrenal incidentaloma? On cross-sectional abdominal imaging, approximately 5 to 7% of the patient has adrenal tumors, and even it is more for older age patient. And incident of adrenal tumor obviously increased in past 2 decades just because of the increase in the cross-sectional imaging. Malignancy has been diagnosed in 5 to 8% of such patient, and there is equal incidence in both sexes. If we categorize the adrenal incidentaloma, 2 things are important. One is it is benign or malignant, and other it is hormonally active or not active. On benign lesion, adrenal adenomas are adrenal adenoma and nodular hyperplasia. Other benign lesions which are not common as adrenal adenoma include myelolipoma, cyst, hematoma, ganglioneuroma. Other malignant tumor include metastatic sarcoma or lymphoma, and adrenocortical carcinoma is the malignant primary tumor of the adrenal. Moreover, pheochromocytoma can be considered as a benign or it can be metastatic. On history and physical evaluation, once adrenal mass is found, exclude functional tumor like cortisol excess, pheochromocytoma, ACC, or any primary tumor. On examination, blood pressure, pulse, central obesity. Moreover, specific feature of the Cushing syndrome like echismosis, wide red to purple, stria, proximal muscle weakness, hirsutism, or other sign of virilization in female patient should be always examined, and comorbidity like hypertension, diabetes, osteoporosis, cardiovascular disease should be evaluated. Which can be the imaging modality available for adrenal mass that include unenhanced CT, contrast enhanced CT with washout characteristic, and MRI with contrast that is available. FDG PET is usually reserved for a history of the extra-adrenal malignancy to find out metastasis, and for ACC staging and follow-up also FDG PET requires. First imaging generally found on USG abdomen or other modalities. Generally unenhanced CT we can do, and MRI with chemical shift analysis can assess lipid content of the lipid content within adrenal mass. If HU less than 10, it is indicating lipid rich region. So homogeneous adrenal mass with HU less than 10 is definitely benign. And venous extension of the tumor, generally ACC into renal veins, which can be assessed on contrast enhanced study, which is better done by MRI. For intermediate adrenal lesion, those with HU greater than 10, a dedicated adrenal protocol CT is beneficial. And if HU is greater than 20, there is a 20% risk of malignancy or pheochromocytoma. So what is adrenal protocol CT? Adrenal protocol CT includes it focuses on adrenal gland. Moreover, it includes pre-contrast, 60 to 75 post-contrast phase, and 50-minute delayed imaging phase. And in some of the cases, arterial phase may be required to evaluate pheochromocytoma. Absolute washout is calculated as a post-contrast HU minus delayed HU divided by post-contrast HU minus pre-contrast HU, and multiplied by 100. And relative washout can be calculated as a post-contrast minus delayed HU and divided by post-contrast HU. So what is important of this washout? Patient will have benign adenoma if absolute washout is greater than 60% and relative washout is greater than 40%. Though it is not absolutely correct in every setting, but it can guide us for further management of the adrenal mass. If adrenal mass is found on MRI, adenoma is isointense with liver on both T1 and T2 weighted imaging. Pheochromocytoma has generally high signal intensity on T2 MRI. It is also called as a light bulb sign on the MRI, T2 imaging. And ACC, adrenocortical carcinoma, is hypointense with liver on T1 weighted MRI and high to intermediate signal intensity on T2 MRI. How tumor size and laterality can give us idea. The risk of malignancy is proportional to tumor size. Generally 4 centimeter cutoff is the taken. Greater than 4 centimeter prevalence of malignancy is 31%, while less than 4 centimeter is very less incidence. Median size of adrenocortical carcinoma is 10 centimeter and ACC are generally unilateral. If it is found on FDG PET, it also good modality to differentiate between benign and malignant mass. Adrenal to liver SUV ratio greater than 1.8 demonstrate good sensitivity and specificity for malignant mass, but false positive and negative can occur, and pheochromocytoma are also FDG avid. When adrenal biopsy is indicated, it has poor accuracy in diagnosing ACC. So, if you are suspecting ACC, the adrenal biopsy is not should not done, because there is a high risk of needle track seeding, and it can ultimately lead to worse prognosis. But it is useful in indeterminate non-functioning adrenal mass other than ACC, like adrenal metastasis, sarcoma, or lymphoma. And moreover, infectious etiology, which is relatively common in India, it is fungal and TB of the adrenal gland. And so now we come to laboratory evaluation. So any adrenal mass which is greater than 1 centimeter, all patients should undergo 1 mg overnight dexamethasone test to exclude cortisol excess. And if CTHU is greater than 10, all patients should have plasma or urine metanephrine to exclude pheochromocytoma. If there is a history of the hypertension or unexplained hypokalemia, as earlier said by sir, primary hyperaldosteronism should be ruled out. And if SSC is suspected, elevated sex hormone and steroid precursor can be non-invasively confirmed diagnosis before even adrenalectomy. We will see which steroid precursor we can advise. In case of the bilateral adrenal mass, it is very important to exclude adrenal insufficiency, and it can be done by morning plasma ACTH and serum cortisol. Regarding laboratory assessment of the cortisol excess, MACE is the word. It is mild autonomous cortisol secretion. It is defined as a adrenal incidentaloma plus abnormal 1 mg dexamethasone test and plus absence stigma of the Cushing syndrome. So patient does not have any clinical feature of Cushing syndrome, but on 1 mg dexamethasone test, it is greater than 1.8 microgram per DL cortisol. So 1 mg dexamethasone should be taken at 11 p.m. and morning before 9 a.m. Serum cortisol report should be done. And if it is between 1.9 to 5, it is possible autonomous cortisol secretion. And serum cortisol level post dexamethasone, if it is greater than 5, it is a evidence of autonomous cortisol secretion. Cortisol co-secretion is also relevant for risk of developing adrenal insufficiency after unilateral adrenalectomy. As if patient is taking exogenous steroid, the HP axis will be suppressed. As you know, same thing can happen if a patient is having autonomous cortisol secretion. HP axis can suppress, and post-operative patient can undergo hypotension. So this autonomous cortisol evaluation should be done for every patient with adrenal mass. I have done some 35 adrenal incidentaloma cases during my residency time, and most common adrenal mass during their study was pheochromocytoma, myelolipoma, and other masses include SCC, adrenal metastasis, lymphoma, lipid-rich adenoma, adrenal tuberculosis, leiomyoma, adrenal cyst, and other masses. Most of the benign tumor are adrenocortical adenomas, and it is most common adrenal mass. It present 85% of the cases. 50 to 60% of the adrenal adenoma demonstrate biochemical evidence of the adrenal hormone excess. And most common hormone excess, as earlier we have discussed, mild autonomous cortisol secretion. Median tumor size is 1.5 to 2.5 centimeter, and 95 to 98% of adenoma are less than 4 centimeter. That is why 4 centimeter cutoff is taken to differentiate between benign and malignant masses. Around 60% of the adenoma are lipid rich, so their HU is less than 10. There is no malignant transformation is reported in any patient initially classified to have benign adrenal tumor. So ઘણી વખત પેશન્ટ પૂછતા હોય કે benign અત્યારે છે તો આગળ જતા malignant થઈ શકે કે નહીં, તો so answer is no, and patient can be managed non-surgically if no other indication. This is one of the picture of the lipid-rich adenoma. HU is less than 10, and it is more of a homogeneous, and it can have this type of the adenoma can be non-functional. It can be cortisol secreting, or it may be primary hyperaldosteronism can be found. Regarding management, repeated imaging in homogeneous adrenal mass less than 4 centimeter with CTHU less than 10 is not recommended, because there is a chances of malignant transformation and size increase is very less. In case of non-functioning lipid poor adenoma, follow-up imaging should be done up in 3 to 12 months. Additional testing may be required at the time of diagnosis, such as alternative imaging with CT contrast, washout, or FDG PET, or blood or urine steroid profiling can be done for SCC. Adrenalectomy may be recommended for intermediate masses. Risk of developing overt hormone excess in initially patient diagnosed as a non-functioning adrenal adenoma or MACE is also low. So patient developing Cushing syndrome or other androgen secreting tumor from non-functional adrenal adenoma is very less. However, patient can have minimal autonomous cortisol secretion, so repeated 1 mg dexamethasone suppression test should be considered. If patient has a benign adrenal mass and autonomous cortisol secretion, then treatment, if patient has a primary adrenal Cushing syndrome, then treatment of choice is adrenalectomy, and if patient has a MACE, then management differs in a different scenario. MACE is associated with higher risk of the cardiometabolic condition. It is associated with high risk of the high prevalence of the hypertension, obesity, dyslipidemia, type 2 diabetes, and CV events. And there is a significant risk of osteoporosis and asymptomatic vertebral fractures also there. MACE patients who are adrenalectomy generally experience improvement in blood pressure, glycemic control, and dyslipidemia. So which patient with autonomous cortisol secretion should undergo adrenalectomy, unilateral adrenalectomy? So patients who are younger at the age of diagnosis, more level of post dexamethasone cortisol level, more higher degree of the MACE, and they people can undergo adrenalectomy like above 5 or above 3 or 4 levels. More recent onset and exacerbation of the potential cortisol related comorbidity, patients should undergo adrenalectomy. In case of the bilateral masses, unilateral adrenalectomy of the larger mass can be advised. There is here this is a mass, and there is two component. One is the very much black, which is fat component, and other is the hematopoietic precursor cell. This is myelolipoma. Once this type of image is seen, you can diagnose the patient without radiologist report. So myelolipoma is the incidental benign tumor composed of the bone marrow elements, and that account for the 2 to 6% of the primary adrenal lesion. These tumor contain large amount of the fat. Most myelolipoma can be easily recognized on CT. These myelolipoma have negative HU, so it is like this tumor has a HU of the -10, usually unilateral, and 20% of the patient may be have large tumors. Occasionally, large tumor or those who are undergoing tumor necrosis or spontaneous hemorrhage may cause flank pain. They should undergo adrenectomy. Occasionally, these patients may have adrenal hormone excess, and this may. So this picture of the ACC, it is very heterogeneous mass. Area of the necrosis and bleeding can be seen, and patient has a poor washout on the adrenal CT contrast evaluation. ACC generally present with the rapidly progressing Cushing syndrome with or without virilization, and adrenal androgen secreting ACC in women present with the hirsutism and virilization with male pattern baldness and oligoammonia. ACC are heterogeneous and demonstrate greater than HU greater than 20. These are some of the tests which must be done if ACC is suspected, like dexamethasone suppression test, endostenodione, testosterone in women, and estradiol in male, and postmenopausal. Mineralocorticoid excess should be evaluated. Surgery with en bloc removal and wide local excision offers only chance of cure, but metastatic spread is seen in 75% of the cases. થોડું pheochromocytoma બોલો. This image of the pheochromocytoma. Initially, unenhanced image has a low HU, but after arterial enhancement, there is a significant light bulb like picture can be seen, and arterial phase HU was 117, which was significantly higher than unenhanced HU. Median size of the pheochromocytoma is 4 to 5. Plasma and urine metanephrines is advised for the diagnosis of the pheochromocytoma. False negative result for measurement of the metanephrine are rare. So if it is normal, we can exclude pheochromocytoma. For plasma metanephrine, blood should be collected in patient with supine, or should be at least for 20 to 30 minutes. So blood should not collected if patient is in sitting position. And urine metanephrine greater than 400 and normetanephrine greater than 900 is suggestive of pheochromocytoma. All patients with biochemically positive pheochromocytoma should receive preoperative management, and hemodynamic goals include supine, systolic, and diastolic blood pressure should be 130, less than 130 by 80. SBP in upright position should be between 90 to 110, and heart rate should be less than 80 in supine position and less than 100 while standing. For proposed algorithm, prazosin should be started in 2.5 to 5 mg dose at least 7 to 14 days before surgery. Liberalize oral salt intake and fluid intake. Add selective beta-1 blocker after 2 to 4 days, and administer saline infusion 12 to 24 hours before surgery.